Good evening, everyone. Thanks for joining us today for our Grand Rounds presentation. We're very excited to introduce two of our fantastic faculty from the CU departments, Dr. Stoneback, who's the Associate Professor and Vice Chair of Clinical Affairs, and Chief Orthopedic Trauma and Fracture Surgery, as well as the Director of the Limb Restoration Program, as well as our own Dr. Catherine Payne, who's the Medical Director of the University Rehab Center, as well as the Assistant Professor in the Department of PM&R and faculty member of the Limb Restoration Program. They'll be discussing OSTEO integration in our new program on campus. Thank you so much.
All right, thank you for that introduction, and thanks for the opportunity to come speak about a little bit about this topic. It's really exciting. Spent a lot of time over Dr. Payne and myself, as well as the rest of the team, working on getting this together over the past 2.5 years. So it's really been a real treat to do our first 5 transfemoral patients and first 2 tibias. So this today, and we split this up a little bit, is to go over a little bit over the history and the origins of osseointegration and where it came from. And then a little bit about what we look for in the preoperative assessment, a little bit about the surgical technique, and then Dr. Payne talking a little bit more about on the rehab side of what we're doing in these very specialized patient, in this specialized patient population. We want to try to leave you with some thoughts on who may benefit from this, and who really aren't great candidates as well. So I'm speaking to the pros here. You all know what this is like, but this is one of the patients that we, not his real name, that came for an evaluation from out of state. And when he was 15, he started having thigh pain, ultimately was waking up at night, began having, just constant pain, and ultimately was diagnosed with osteosarcoma. Devastating, right? Horrible. Ultimately underwent transfemoral amputation, chemotherapy, all of that was, disease-free, declared disease-free at 5 years. So most of us think, oh, that's a win, right? Well, fast forward, now he's 22. So while we think he should be very, doing well, we beat the cancer, he's not doing that great. So when he came to be evaluated by us, you think, oh, he's 22. At least I do. I'm like old man now, 41. I'm like, that's what he's doing, right? He's out with his friends. He's hanging out. They're having a great time. But what he told me is, I always ask our patients, I said, what do you want from osseointegration? Because we want to try to figure out, or do you have realistic expectations? And what he told me was pretty powerful. He said, I want better relationships. And I said, what is that? What do you mean? And he said, well, when my friends or acquaintances or somebody at work that I just met says, hey, what are you doing tonight or whatever? Do you want to go this weekend to the movies? He said, I'm super worried that my leg's going to fall off because it happens all the time. He said he was walking with his boss down the street. His leg just keeps falling off. He has a unstable soft tissue envelope, and they've tried to fit him with everything under the sun in the terms of a prosthetic. And so he said, what he battles with is, do I tell them that I'm worried that my leg's going to fall off, so I don't want to go? Or do I say, thanks for calling, I really appreciate you, but I'm just too busy to go? For me, that was, pretty much hit home there. Then we have Donna. So when she was 31, she was involved in a horrible car accident, smashed her knee. They fixed it, thought everything was good. She had a problem with that, ultimately had to have a knee replacement. Then she was involved in another car wreck that tweaked that knee. She had 5 revision total knee arthroplasties between 31 and basically 53. So now here she is at 55 years old. She used to ride horses, was very active, and she's describing to me what it's like to function as an above-knee amputee every day. And she's telling us how she doesn't know how she's going to do this when she gets older because she's afraid her fingers are going to not be strong enough or, become arthritic with age. She has to refit this because she gets wrinkles in her residual limb, has to take it off and start over. She puts on her prosthesis and it's twisted or it shifts during the day. You all know these descriptions, right? So Dr. Payne and myself and a bunch of other people on campus are involved in this limb restoration program, which is a limb salvage service, which I hate that name. That's why we call it the limb restoration program. So, because it's about restoring patients' form and function, right? It's about getting them back to their optimal self, whatever that may be. Is that healing or lengthening a bone or flapping a large soft tissue defect or doing limb sparing type of operations. We're doing a well-performed amputation or taking care of patients with amputations who are not doing well. That's what it's all about to us. So this type of patient population was near and dear to our heart, and when and that's what we're going to talk about, how we got to osseointegration. So as a part of the limb restoration program, we have this dedicated amputee service, which Dr. Payne heads up. Now, in addition to that, we're involved in research with CSU, partial canine limb amputees, which is a lot of fun, multiple research trials. It's been great. So as you know, we've had a growing population of amputees, especially with the wars and the IEDs, most recently in U.S. history. We all know the statistics on how bad it is for amputees and how long it takes them to return to work. Many of them don't. Or especially if you're a bilateral above-knee amputee, how much energy and effort it takes to try to be functional. So what are those challenges that these amputees often face, especially our war victims or being at this level in trauma center where we have the only ABA certified burn center in the region? We frequently see these horrendous scars, difficult soft tissue envelopes, and short residual limbs, right? Makes it very difficult for prosthetic fitting in a traditional sense. Patients experience these pistoning where as they ambulate, they sort of piston in their sockets. Above knee amputees hitting the side of their socket with their residual limb and abduction can be very painful. Patients describe problems with all sorts of problems with groin wounds and things like that from prosthetic wear. And they have really poor proprioception. So that leads to decreased walking confidence. Decreased walking confidence. Patients will frequently say, I don't know, I'm standing on people's feet all the time, or I feel very awkward at social functions, things like that. So the answer may be, for some of these more difficult patients, to get a good socket fit and who have some of these issues, the bone-anchored prosthesis. That's the generic term for osseointegration. So you can see the difference, socket versus the bone-anchored prosthesis, which instead transforms the prosthesis to something that you're sort of sitting in or wedging on to really a part of you, reattaching that limb, much like a cyborg type of thing, right? Like things that seem very futuristic, to your skeleton permanently sticking out of the bone. So this was actually developed in Sweden and came from Professor Brandemark in regards to dental technology. So it was started in the 1950s by Per Ingvar Brandemark, and it went through this characteristic state, and this will be a theme you'll see. It really hasn't changed that much. So the first stage is where the old tooth is removed, revision amputation. The titanium implant in the dental world is then inserted into the bone. The soft tissues or the gums are then closed over this implant, and it's left for a period of time and it's allowed to osseointegrate. And what is osseointegration? Osseointegration is osteobone integrating into that metal interface, okay? Very similar to hip implants, total hips, where we press fit. We actually broach the bone, and then we put a slightly oversized implant into that canal, and it is pressed into the bone, and then has a porous surface that allows the bone to interdigitate like mini fingers, microscopic fingers, into the bone or into the metal interface. So that's what happens during this time, and the theory is it's a sterile environment with the gums closed over that allows this process to occur. Once the bone has osseointegrated and you have a stable bone-anchored implant, they then come back and open the soft tissue envelope and put in this what's called an abutment. The abutment is just this attachment into that sort of the roots, if you will, of this bone-anchored prosthesis. And then ultimately you can put on whatever you want, just like a prosthesis, right? So, Ricard Brandemark, Per Ingvar's son, then took this sort of thought process and said, well, if we can do that in the mouth, the dirty mouth, we could do this maybe in an amputee, right? So he's an orthopedic surgeon and developed this technique with a screw-in type device. So you can see that the fixture up there, it screws into the bone, into femurs, and then the soft tissue envelope is closed, allows it to integrate, and then you come back, make a hole, and basically attach this abutment. So early results were pretty promising. So 92% survival rate of the actual the fixture that's integrated into the bone. Superficial infection rates pretty high in this, these early studies, around 60%. Now, it sounds scary, but it's really not that big a deal. I'm not going to try to bash this implant one versus another, but I do think there's been a lot of improvements over this original implant that's decreased our infection rates. But most importantly, we've learned a lot about how to decrease that. But these infections, when they do occur, can be dealt with oral antibiotics and resolve. Okay, done in a two-stage technique, just like we talked about the dental implants. He did it just like that, but okay. So placed the screw in there, closed the amputation up, allowed it to heal for quite a long time, 6 months, where the patient can't wear a prosthesis, which is a downside, and then come back and put the percutaneous component and then begin ambulation. On down the road, he looked at 5-year follow-up in these patients and saw some other mechanical issues. So still the actual bone-anchored prosthesis had about a 92% cumulative fixture survival rate, but revising, there are different components, and I'll get to that in a minute, that were bending, and that's sort of a weakness of this system. These things called the abutment that goes inside the fixture is mechanically weak in this particular implant and bends. 4 fixtures had to be removed, but the biggest thing was that there's serious, significant improvement in patient-reported outcomes on all levels, and I'll get to that a little bit more later. So right about the same time as Ricard, who's a good friend of mine, he's a great guy, with the dental type of technology was coming along, another gentleman named Horst Aschoff said, why don't we do this like orthopedic surgeons do it with hip implants? So do like a press fit type technique and see how that goes, okay? So in '99, he developed this press-fit technique, but it saw a horrendous failure rate, like 80% infection rate, having to explant these things, lots of revision surgery. I mean, really bad. But that was what we figured out, or what Horst figured out, was that had a lot to do with how we were handling the soft tissues, and in multiple ways. Number one, this is the original integral leg prosthesis. So this big outrigger would actually fit. So you would put this stem. No. You would put this stem in the femur, and then this outrigger went on the outside, and then you put some more screws in it, like orthopedic surgeons do. We're like, yeah, more is better. We need more screws, we need more metal. That's the answer. And then on top of that, there's this porous distal coating, and the thought was we have to seal this out, the skin to the outside. So what we'll do is make this porous coating and seal the skin to it. This is a great idea, right? Well, this is what happened. Like all sorts of just wicked infections and angry soft tissue envelopes, and it was horrible, right? So we said, okay, that's a bad idea. We need to get rid of this porous thing. The skin doesn't like it. We'll get rid of that. We'll make it really polished. But we still need that outrigger thing. We'll just make it a little smaller. Still less problems, but still having issues, right? So now this is the present day implant. You can see the outrigger thing is removed. It's very low profile. That rough area is the osseointegration surface where the bone grows in, and the rest is smooth. The key is making this smooth so that the skin has less irritation. So kind of figured that out. So this is me and Horst in Hanover when I was training to do this stuff. And he is a plastic surgeon by training, which is interesting. So he is credited, at least in my mind, of really figuring out how to decrease infection rate and handle the soft tissues. So we have an orthopedic surgeon that was basically coming from a dental practice, and then you had a plastic surgeon who is, implanting metal into people. But what he's very good at is here's an irritated soft tissue envelope, and he showed me these drawings on his computer about how he will revise the soft tissue envelope, take away any excess skin and muscle to really decrease how much that soft tissue envelope is pistoning on these metal components. So when you look at his data, this is a follow-up study of his, and here on the left side, you can see the red is the stoma, so this percutaneous part where the metal is sticking out. There's lots of muscle there, and it's basically a lot more area and room for bacterial colonization, okay? So what he figured out over time was we had to remove everything we possibly can. So these operations are actually almost like plastic surgery. The bone part's relatively straightforward. It's the soft tissues that's the challenge. So once he figured this out and figured out the implant, making it more, less abrasive to the skin, that sort of thing. Now the way we do this is more on the right side. We want as much skin, fat, soft tissue, and muscle removed as possible, and to have this nice, elegant bone implant interface. Okay, this is what a more modern stoma looks like. So if you look at the top, design AB were those first two with the outrigger, the first beast with the porous coating on it, that sort of thing, and then C is the present day implant, which has been even improved upon in there since then. So if you look at early soft tissue infections and late soft tissue infections, vastly different, huge. Once we figured out how to manage the soft tissues, and then number of implants went from 13% down to 0. Obviously, the follow-up was a little bit different, 74 months versus 32 months, but those numbers have been holding true. It's at least less than 10% of explantation rate, okay? So big change. So this phenomenon of osseointegration sort of was used in multiple areas. Dental, we talked about dental prostheses, facial prostheses, hearing aids, fingers. You can see like the thumb, that sort of thing. So, and then lower extremity amputations. So it's really been used in various ways. So what does that mean in our amputees? So we've all seen the X-ray on the left here. Okay, patient with a traditional socket that's hitting the side and abduction of their socket when they ambulate, right? So the their femur is abducted. The way their body force is down, the abduction of that femur causing pain, discomfort, and difficulty with prosthetic fit. When we read anatomy in a normal way, we can then bring that femur out of abduction and stretch their abductors out, as well as their hip flexion contractures over time, and get them back to a normal gait, and they actually begin using those muscles and can build muscle and actually build bone because they're loading the bone as opposed to bypassing it. Okay? Trouble is that none of these devices are fully approved in the U.S. So there's primarily done in Europe, where I had to travel and learn and do surgery there in order to bring this technique back. Okay. Now there's been sort of an explosion of this press fit technique. We've had multiple different design configurations, and you can see that these devices are custom to the patient's anatomy to accommodate very short residual limbs, different diameters of bone and links, etc. What's really interesting is that we found that when patients are often osteopenic and have very poor bone quality because they haven't really truly been weight bearing through the bone for quite some time. So when we implant these devices, over time they actually will build bone, which is pretty interesting. Okay, we don't see significant change in bone mineral density in the head and neck, which would be nice, but this was just a 2-year follow-up study, so more long-term follow-ups probably needed. One of the most profound things are the improvement in patients' overall function and quality of life. So here's some of my colleagues, Jan-Paul Frolke, who trained me surgically. This was a study of theirs, and if you look at QTFA reported outcomes, statistically significant improvement in their quality of life on all scores. Hours of prosthetic use, statistically significant improvement in how often they use their prosthesis, how far they can walk. They decreased timed up and go, so they can get up faster and get moving quicker, and decrease oxygen consumption. So it's a game changer for amputees, especially those amputees that are having difficulty with traditional socket wear. So what are some of the benefits? Probably the coolest thing is osseoperception. There are a lot of benefits, but osseoperception is their ability through the bone to perceive their environment, how much force they can feel. They can feel where they are on the ground through their prosthetic limb. So one of our patients, Donna, actually stepped on me and said, "Oh my gosh, I can feel I'm stepping on you," and she was amazed. They can feel vibration. They can tap on the end of their implant and feel that. They can feel uneven terrain. One of our colleagues said that he has to take off his legs because when he's four-wheel driving because it's too much feedback, which is interesting. But truly a game changer. Can feel how much force they have through their limb, improve quality of life, mobility and functionality, not having to sit on a socket at dinner for a couple hours. Imagine that. So really, really a game changer for these patients. So currently it's only in post-traumatic amputees and those for tumor-related conditions. But we're currently looking at, can we do this in certain diabetics? Obviously, we know vascular paths and diabetics are the largest patient populations, vastly larger than those other two. So we need to figure out which of those patients in those populations can we treat. That's one of the things that we're looking at. So here's a closer look at the screw-in device. This is what it looks like. So during the first stage, there's a revision of the amputation. This screw is placed into the femur. This is being done primarily in Europe and at Walter Reed. So I spent some time with Ricard out there at Walter Reed and the guys there taking care of veterans, and this is the implant they're using. So the bone graft is grafted in there, and then the residual limb is closed, and the bone heals over this, and it's a little bit different technique, but this is sort of what it looks like. The press-fit implants are all sort of similar in terms of there's the actual intramedullary implant with this porous surface that's implanted. Then there's a percutaneous component called a dual cone and dual cone screw that go through the skin and is tightened in there. From there, everything, the taper sleeve and the connector and then the prosthesis is connected, okay? So this is what that looks like. So you have an existing amputee. Go in, there's a lot of surgical planning about knee center, how much bone to resect to get to good bone, as well as to accommodate componentry. So there's a revision of the amputation, reaming of the intramedullary canal, and then we press fit the implant into the bone. So you take the actual implant and just like a hip joint, we sort of press fit this and actually pound it into the bone, and then close the femur and allow it to heal. 6 to 8 weeks later, we come back and then make what's called a hole, or the stoma. So that's where we make this percutaneous. It's an outpatient surgery. The soft tissues typically retract. The dual cone is then inserted, and then your prosthesis. Okay? And this is the type of device that we've used at this institution now thus far. Yes. Yeah. And I'll go through it a little bit. So I know Dr. Payne's going to touch on this, so I'll kind of breeze through this, but we have the process for evaluating these patients. There's a pre-screening questionnaire. Major inclusion criteria is skeletal maturity, having difficulty with prosthetic wear, trauma or tumor, although we have done other patients who've had amputations for other reasons. Major exclusion is tobacco smoking, anything that would affect healing like immunosuppression, things like that, and peripheral vascular disease. They then come and we have these large multidisciplinary clinics where they meet a surgical team, PM&R, and prosthetics team, and then they also meet osseointegrated patients for a peer-to-peer so they can actually see what it's like and wrap their heads around that, ask questions that only those types of people can answer. A lot of preoperative planning, custom device manufacturer. Here's an example of that with, this is one of our tibia patients where we had to decide how much bone to resect, et cetera. So there's a lot of planning that goes into these. The first stage, and this is how we were doing, this is you going back to the dental technique, right, is we do a revision amputation, insertion of that intramedullary implant, a lot of the soft tissue work, removing excess muscle, skin, scar, and really creating a tight soft tissue envelope. So the vast majority of the surgery is the soft tissue work, okay? They're usually in the hospital a couple days. Here is some surgery I did when I was in Europe. We're revising the soft tissue envelope and then putting the implant in. Just tapping in, there you go. This is what we do. It's not that hard. We just like hammer stuff. Then this is a big part of it. Right before we implant the implant, we do take some soft tissue sutures and anchor the muscle to the bone to create a good myodesis, and then tap in the implant. Then a lot of time is spent removing excess tissue we don't need, okay, so that we avoid those problems that Dr. Ashoff figured out. Then we pull the soft tissue envelope over the top of the implant, allow 6 to 8 weeks for osseointegration to occur, and then we come back during an outpatient procedure, create the stoma, and insert this dual cone. This is what it looks like intraoperatively. That's the actual implant sticking outside of the, through the stoma, cleaning it out really well. Need to edit videos. Anyways, dual cone, open it up sterilely, and then place it into the implant. There's a Morse taper, so we actually impact it in there, and that holds it. In addition to in addition to the screw that goes inside. Okay. Now, sometimes soft tissue envelopes, especially in tibias, we don't have enough soft tissue envelope to do a two-stage technique and actually close it. So we've been doing those more in a single-stage technique, although they can be done in a two-stage technique. And that's where this is all done at once. So we revise the soft tissue envelope, put the intramedullary implant in, fixate it, and then create the stoma, attach the dual cone all in one shot. And this is sort of what that looks like. In a tibia, much of the same procedures. Pull that soft tissue over. We actually hold it in place and then create the stoma. I'll sort of fast forward. Dual cone, same thing. So end result is, looking at this gentleman on the left, imagine this. So you can just clip on your prosthesis. Get up and go. You can feel how much pressure you're placing through the ground. It's pretty significant. This is our first transfemoral osseointegrated amputee. This is her pre-operative evaluation where we were watching her walk with her traditional socket prosthesis. You can see how, she has that typical gait pattern, and then this is an osseointegrated amputee who's several years out, 4 years out. Vastly different. And that is her skin. There's nothing there. So here's one of our patients. What she looked like pre-operatively. This was after stage 1. You can see the soft tissue envelope is closed. This is Donna, and she's been in the news and everything, or is going to be. So she's said, you can use my pictures in any talk you want. So this is her stage 2 procedure. This is a couple hours after her outpatient surgery. When we place the dual cone, this is what she looks like today. One of our other patients, traditional or that characteristic X-ray, right, with the abducted limb. Here she is with already having a significant contracture just within. This was like a week or two. Yeah, this is within a week. Where she's already correcting. So we actually, instead of your prosthetist accommodating a flexion contracture and an abduction contracture, we actually under-accommodate it and force the patient to bring their limb back and stretch those muscles out.
So you're not surgically adjusting that contracture in any way?
this is all them stretching it out. I'm just matching the anatomy. And then when post-operatively, so they come out like this with metal sticking out. Yeah, it's sticking out in the right field. Well, you attach the prosthesis, and then they're forced to stand correctly with the physical therapist, right? And they stretch, okay? And it's impressive. So here's our group. First 5 femurs, all doing really well. They were here in Denver for 3 weeks doing rehab. They just left right before Thanksgiving. And our 2 tibias are now currently in rehab in town. So here's Donna, just to give you a picture of, this was maybe a week and a half post-op from her second stage. She has a little shrinker on, but basically nothing else. Another one of our patients that has a pretty significant abduction and flexion contracture, and you can see they're accommodating for that with an offset, but she's already now to a lesser one, okay, because she's stretching and improving with time. More of the same. This is early, about a week into actual attachment of their prosthesis. Doing really well. So we're in the process of working on IDE trial to bring this into, a formal study within the United States with our partners in the Netherlands and other parts of the world. Tons of opportunities for research, mainly in the diabetic and vascular patient population, clinical trials, improvements in technology, future directions with like regenerative peripheral nerve interfaces as well as TMR. How can we, now that we can have a bone-anchored implant, we can attach myoelectric limbs directly to the skeleton. So it's opened up all sorts of opportunities for that, and it not being too heavy and that sort of thing. So in summary, osseointegration started in the dental industry. There's basically 2 different techniques. Implant removal with more modern implant design and techniques is less than 10%. Superficial infections are common, but don't necessarily mean failure. Significant improvement in quality of life, and there's lots of opportunity for research, innovation, and improvement. Big team couldn't do it without everybody. A lot of these people and many, many more helped bring this program to the campus. Thank you. And we've got Dr. Payne up next. Oh, sorry.
All right, here we go. I think we're good. So I was just going to highlight a few of the things that Dr. Stoneback went over already, and I want to just do it briefly so we can make sure we leave enough time for questions for you guys. And I think, we went over a lot of this, so I'll breeze through most of what I have up here. But so focusing on some of the selection criteria, the big thing that I'm really looking for in clinic is kind of that failure with traditional socket. So a lot of that's related to pain, poor suspension. Some of the folks that we're seeing have recurrent infections and skin issues. Certainly the very short residual limbs. And then, as Dr. Stoneback gave some examples of that soft tissue scarring or skin grafting. So I'll have some pictures of some of those. There's a patient some of the residents may have encountered that's a 90% burn that has quadruple amputations who we've assessed as a potential candidate. So that kind of injury are the exact patients that we're really trying to help. And then the other main thing that we're looking at is this someone who's going to be compliant with the program? So it's something where there's a lot of processes and things they have to participate in, and if they are not adherent with it, they're not going to be successful. So some of that can be as simple as when I'm seeing someone and they have old liners and you can tell that they've never seen their prosthetist in 5 years. That makes me concerned that they're going to have that good follow-up. So we're looking at that kind of big picture. And then their willingness to be able to be here, like right now when we're having patients who are coming from across the country to have this procedure done, we're asking them to be in Denver for weeks at a time. So just kind of their knowledge and making sure that they are on board for this whole process. We briefly touched about some of those contraindications. I think a big thing, again, is this kind of non-compliance, so that we're kind of trying to screen for that in the personality. The people that we're seeing right now are highly motivated. These people have been researching this for years, like this is not an issue. But I think as this is becoming more mainstream, it's something that we have to really be mindful of. And then again, just if their conventional socket technology is working, we don't need to do this. And then that's, I would say, for transfemoral, this is really life-changing. For the transtibial, we really have to be mindful because there are some activity restrictions that go along with this. So right now, the guidelines are that you cannot do high-impact activity. So if you have someone who's a transtibial, they like to go running, they do CrossFit, whatever, this may not be the best solution for them because they're not going to be able to do some of those activities afterwards. So that's kind of really getting a sense of what are their goals, what are we trying to do, and making sure that we're in alignment. So I just wanted to show a couple of our actual patients and kind of their residual limbs before and after. So this gentleman kind of typically has some of that irritation. You can tell he's been really putting stress on the distal end of his residual limb, chronic poor fit, lots of irritation in his groin. He tends to just power through and despite the pain. And so after surgery, this is now his limb, and he's doing really well. But I think it's really fascinating to see these limbs afterwards, after Dr. Stoneback has done his magic with the surgery. This is another gentleman that is an example of a transtibial that clearly has a lot of soft tissue challenges. He's had chronic problems with fit. Unfortunately, when he, most recently went in for hardware removal and preparation, found he had significant underlying infection and now had to be converted to above-knee amputation. But this is kind of the type of limb that we're looking at that we could really make an impact with. And then another patient that's transtibial, that was a traumatic injury with grafting. So she's had a lot of challenges with soft tissue as well. And that's her post-op. So you can kind of see how there's been that soft tissue revision and kind of things are in a little bit different position than before. Yeah, it'll change over time. So in general, just from a really quick rehab approach, we are counseling people about some prehab prior to their first stage. So typically working on contractures and strengthening, making sure people have good single leg stance, and then we're also encouraging people to practice getting around their home without their prosthesis. So despite having a lot of pain and trouble with their socket, a lot of people are still using it for function. So we want them to practice and make sure that they can get by for 6 to 8 weeks at home without their prosthesis. Because these are all typically patients that have been amputees for a while, so they're used to using their leg. And then once we start the actual rehab program post-op, there's a gradual progression of activity. So typically, they're starting in parallel bars and actually fairly quickly progressing to, we've been having them use the forearm crutches, and then eventually we'll be going to a cane and then single point support. And so that's a 3-week program, and then we transition people back to their home states and cities where we're in communication with their home PTs to help continue this process through the next, generally like total of 12 weeks. It could be longer if people need it. So here's a couple of videos. Oh, I guess before I go into these, one of the other really neat things about the way this program is working is that the therapy sessions, as you could see from that last picture, is of Dr. Stoneback's presentation, all those patients are together in a group during therapy. So there's We do some kind of group class type interaction with PT and as well as the individual, but it's a really interesting environment to have the patients kind of going through this experience together, learning from each other and kind of giving each other feedback. So it's a really interesting and fun experience. So this is one of our transfemorals, just to give you some different ideas of their where they are progressing in their gait. And I think all of these, I have a couple of them. So this is Donna, the famous Donna, who's been on all the things. But this is her, I think, pretty close to when she was going to finish that 3 weeks. So we saw a video of her earlier when she was first starting to walk out of the parallel bars, and here's her just racing along. So her gait speed is significantly increased, and this is just, I don't know how far apart those videos are, but like maybe a week. Slow them down. Yeah, exactly. And then this is the one woman who was in it initially where we could see some of, actually, did you, I don't know if you had her. Can't remember. But her initial gait pattern was a very significant compensated Trendelenburg. Oh no. Clicked the wrong thing. So this is her now, which she's doing really well. And then I have the same X-ray that Dr. Stoneback had, but just it's so powerful, that alignment improvement. So it's really fun to compare those images. And so the last thing I wanted to just highlight is the osteoperception. So that was briefly talked about, and one of the interesting things that we've seen in some of the previous work is that osteoperception that we're thinking may contribute to improving people's just whole body image. So they're having more of that input, they feel like it's their own leg, and it's really impacting people's, like, just their well-being emotionally and mentally, and they feel like they have their body back, which will be really interesting to see that impact over time. So in addition to having that sensation for just plain walking and avoiding obstacles, it's actually improving people's quality of life from a just body perception, which is interesting because we talk to patients pre-op about making sure they're okay with a piece of metal sticking out of their body. So the reality is that actually probably improves their body image. Okay, so I think those are most of my highlights I wanted to cover, and kind of open the floor to questions, and yeah.
Is that 3 weeks of physical therapy something that you think will need to continually be done on site at whatever center of excellence is doing the osteointegration, or do you think that after a couple more rounds you'll be able to just turn that into a line to let their own PTs and do that?
So I think that it's wise. I think that we'll be able to dial it back. We're creating educational videos. We have Zoom meetings where local offices and physical therapists can talk to our team. But it is so different, so foreign in the environment. It is unlike anything that your average hospitalist has ever experienced. I really think it's really important. That's a great question. That's a big challenge because people, and we have patients calling in internationally, as well, and saying, I'd like to have this done. So, to answer your question, I think it is important, and I don't see that going away anytime soon, because I want them to leave here having the tools and set up correctly for success. And I would be concerned that we've put such a large effort into something like this with, huge potential downside, having to have explantation or revision, maybe to a higher level to hip disarticulation, et cetera. So we want to make sure it goes well. We're going to go down the line. So so far, these patients have all been prior authorized and approved through insurance, through no small feat of a huge team. It's been a challenge, for sure. But it's sort of like the Oregon Trail. I mean, there's no codes for it. No one really knows how to get it done. I've had, huge conversations with insurance companies, and some still deny it. But it's interesting, the one insurance company that denied this individual, the person I was talking to on the other line, he said, "Explain this to me." And I explained it. He said, "This is the coolest thing I've ever heard of, but I have to deny it." And he said, no, and it was really interesting. He said, "But here's my personal email. I want to tell you how I have to deny it, because if I don't, then it goes to the next level and they deny it." He said, "But here's how let me help you get through the process, because this is awesome." So it's been a real interesting experience on multiple levels. Interesting. There are no publications about it that I'm aware of. So Sweden did it? Right. So that's been from the surgeons that I've been training with, that's one of the things that we were really having trouble trying to decide. Do we do TMR first? Do we do our P&I? And they said, no, just do the osseointegration and let the dust settle. And at first, I was like, really? But we've seen it. So they've said, wow, my phantom limb pain went from, some patients got worse after the first stage. And then when we did the second stage, without connecting the prosthesis, it went down. And then once they began ambulating, it was significantly down. So, yeah.
Yeah, and I would just say, with the phantom pain, that is something that if that's their primary reason that they don't tolerate their prosthesis, then we have that conversation about I don't know if it's going to get better or not. We hope that it is, but it's really a better indication is if you're having residual limb pain, or if you can't tolerate it because you have a neuroma that we just can't get under control, then this would probably help that. But the phantom pain specifically, probably, but it's more of a wild card.
So it's interesting because it's mixed messaging, you're quoting that stuff, but the surgeons say avoid, that's not an indication. But it seemed to be this profound, it's real. So I think it needs to be looked at more, but that's not an indication. So the numbers are so low, in the world, that numbers of periprosthetic fractures, there's not really a great, you can't quote. They've been very small. implant failure below the diameter of 15 or 15 millimeter diameter implants and below. We've seen some failures in those. So that's sort of the cutoff that we think. And a lot of it has to do with the internal architecture, at least within the press fit devices. The screw-in device, the abutment, is been a source of problem for that particular device, a lot of bending of it and failure at that level, but not actually the inside implant. We just don't recommend high impact activities. Now, patients still do it, and a lot of them are doing fine, but we don't recommend it. So anything high impact. So I say, jumping from great heights, avoid skydiving, repetitive like running, I don't recommend, but it's been done for sure.
And some of this may change over time. So as we're getting further and further out and getting more data, then we may be more liberal with what we're letting people do.
Yeah, after maturation of the stoma. So that's a fresh, open, so after the second stage, that's a fresh, open, raw wound and a pretty significant source of pain. So they have a lot of stoma-related complaints that first couple weeks. It's very foreign. Just imagine how a paper cut fits. We just made a hole in the skin and we're just allowing a piece of metal to rub in and out of it. So, but as the stoma matures over the next couple months, then yes. Correct. So the screw-in device is under a humanitarian device exemption. So there's a very narrow window for patient selection, only transfemoral. And then the rest are being done under custom device exemptions. So custom devices. And that's why one of the reasons why we're trying to push so hard for an IDE trial. And we're in some talks, to get that done. Mm-hmm.
In terms of expanding the patient population to people with worse risks of compromise and that sort of thing, where do you see as the next steps in kind of that progression?
Research. So, it's interesting because when I was overseas, we signed up a patient, and then the resident came back after we signed him up, and this was in Germany, and said, "Oh, I just found out he's diabetic." And they were in German back and forth, and they said, "Well, he's controlled." And he said, "That'd be okay." So, and then he told me, he said, we don't say that's we're supposed to contraindicating that, but he said, it's okay. It tends to be okay if they're well controlled. Okay. A type 1 diabetic, they say shy away from, but if they're a very well-controlled type 2 diabetic, the way they found out is that they just slipped through the cracks, didn't know they were diabetic, and it happened, and things seem to do, go well. But these are low numbers, anecdotal experience, so we need a lot more strict parameters on those sorts of things, and especially if we're going to entertain vascular paths. Is there some sort of transcutaneous oxygenation level? So our team's looking at that sort of stuff. I think one day it's going to be standard of care. I think we're a long way from that, but I think that one day we'll be there. What do you think?
Yeah, especially for the transfemoral. I think that is going to happen faster.
Yeah. True.
but I think we're a ways out.
Yeah. They're doing it in Australia, and then a few of my colleagues have done it for existing osseointegrated amputees. So it's an interesting population because if you have a person who already has an osseointegrated limb, and then their other limbs not been doing well, and they say it was trauma, and they're like, I'm ready for an amputation, and we're like, okay, cool, we'll try a socket. They're like, no, So in that rare indication, and I currently have a patient that's looking at that, and I'll offer it to him for that. But I think that there's some concerns that this is not without problems, okay? There are issues, you can get infections, all sorts of things, right? I think that part of its success may be because these patients have suffered so long with the traditional socket that when this happens and the little things just aren't that big a deal.
What would it look like in the worst case scenario where things really went off the rails? Could they take the respite thing out and go back to wearing a socket and having those old problems?
Yeah, you have to deal with the infection. It depends if it's aseptic loosening or for septic loosening. The worst case scenario is septic loosening, and then we have to treat that as osteomyelitis, and that basically removal of implant, aggressive debridements, treatment with antibiotics, and then depending on, sometimes you're shortening them to accommodate the implant to get to good bone. So you can. I have one patient who it's a long story. Anyway, she had some sort of fracture. They made this custom nail, fixed her femur. It healed, but it looked very odd. And she's been, having this rod kind of poking out the side of her thigh for a while. And so we said, okay, you're a candidate. We need to take that rod out. We're going to do a deep bone biopsy because you had history of infection. And she wound up having chronic infection in there. It's amazing what chronic osteo how it can hide. So we've treated her infection. I put an antibiotic rod up there, treated all of that, and now we're preparing to implant her. Yeah, so it can be done. Yes, so that's something we have to watch out for, right? So having room, so these devices actually have the custom device that we make or we are using has the ability to attach a total hip to it, so it becomes the anchor point later. They're not, I'm not super not super excited about them. They haven't had great results, and there's been some total hips and total knees done with osseointegration all in a single stage and have failed pretty miserably. So it's something that we're looking at and trying to figure it out. I think that if it's done in stages, then it may be better than if you're just doing it all in one fell swoop, because it's too connected. 7. Yeah. They're mainly one-offs. So the Walter Reed has done the most with the screw-in device, and then there's been a couple one-offs, more what I'd call one-off. UCSF did 10 screw-in device techniques. One of my colleagues in New York has done, maybe somewhere in the teens in terms of number of press-fit implants. So in terms of press-fit implants, basically New York and here in terms of center. All right. Thank you.